Before I begin talking about all of the emotional disorders, I do want to let you know that there are several disorders that will be mentioned in this section, and along with symptoms and causes given. There's a lot of information and there's a lot of disorders, so using a separate sheet of paper aside from the notes pages that you have been given may be an asset to you moving forward in this unit. Almost certainly you can think of times in your life when you felt rather emotional, perhaps a bit anxious or down. These feelings are a common experience for most people, and feeling some anxiety is useful. It can prepare you for upcoming events and motivate you to learn new ways of coping with life's challenges. Being anxious about tests may remind you to keep up with your homework and study. Being slightly anxious when meeting new people may help you avoid doing bizarre things and making bad impressions. For some people, however, anxiety can become debilitating and interfere with everyday aspects of life. Like emotions, moods color every aspect of our lives. When we're happy, the world seems like a wonderful place, and we're filled with boundless energy. When we're sad, we view the world in a decidedly less rosy light, feeling hopeless and isolated. Few of us, however, experience these symptoms day after day. And when a person's emotions, such as feeling sad or anxious, go from being a normal part of daily living to being extreme enough to disrupt the ability to work, learn, and play, the person's emotions are considered to be disordered. We all feel anxious in stressful or threatening situations, but it is abnormal to feel strong chronic anxiety without cause. Anxiety disorders are characterized by excessive fear in the absence of danger. Anxious individuals tend to perceive ambiguous situations as threatening, whereas non-anxious individuals assume they are non-threatening. Anxious individuals also focus excessive attention on perceived threats, and they recall threatening events more easily than non-threatening events. These biases in thinking help to exaggerate the threat and contribute to greater anxiety. More than 1 in 4 Americans will develop some type of anxiety disorder during their lifetime. In one survey of over 94,000 college students, more than half reported overwhelming anxiety within the last 12 months. People who experience anxiety disorders feel fearful, tense, and worried about the future. Anxiety disorders are also responsible for many physical ailments, some of which are potentially serious. Constant worry can make falling asleep and staying asleep difficult, and attention span and concentration can be impaired. By continually arousing the autonomic nervous system, chronic anxiety also causes bodily symptoms such as sweating, dry mouth, rapid pulse, shallow breathing, and increased muscular tension. Chronic arousal can also result in hypertension, headaches, and intestinal problems. It can even cause brain damage. Due to their high levels of autonomic arousal, people who experience anxiety disorders also exhibit restless and useless motor behaviors such as toe tapping and excessive fidgeting. Problem solving and judgment may be impaired as well. Because chronic stress can damage the body, including the brain, it is important to identify and effectively treat disorders that involve chronic anxiety. Let's consider the 5 main types of anxiety disorders. A specific phobia is an unreasonable fear of something that is not likely to hurt you. According to the DSM-5, if that fear impairs your life, causes significant distress, or both, you may have a specific phobia. Specific phobia, a fear of a specific object or situation that is exaggerated and out of proportion to the actual danger, affects about 1 in 8 people around the globe. A specific phobia is classified based on the object of the fear. Common specific phobias include fear of snakes, a fear of enclosed spaces, and a fear of heights. Another common specific phobia is a fear of flying. Some people find flying terrifying, even though the odds of dying in a plane crash, compared with a car crash, are extraordinarily small. For those who need to travel frequently for their jobs, a fear of flying can cause significant impairment in daily living. A social anxiety disorder is a fear of being negatively evaluated by others. It includes fears of being in social situations, public speaking, speaking up in class, meeting new people, and eating in front of others. About 1 in 8 people will develop social anxiety disorder at some point in their lifetimes, and around 1 in 14 are experiencing social anxiety disorder at any given time. It is one of the earliest forms of anxiety disorders to develop, often beginning around age 13. The more social anxiety people have, the more likely they are to develop other disorders, particularly depression and substance abuse problems. Indeed, assessment must consider the overlap between social anxiety disorder and related disorders to make an informed diagnosis. Whereas the fear in specific phobia has a specific focus, the anxiety in generalized anxiety disorder is not focused on one object or situation and is always present. People with this disorder are constantly anxious and worry incessantly about even minor matters. They even worry about being worried. Because the anxiety is not focused, it can occur in response to almost anything, so the person is constantly on the alert for problems. This high level of alertness results in distractibility, fatigue, irritability, and sleep problems, as well as headaches, restlessness, lightheadedness, and muscle pain. Just under 6% of the U.S. population is affected by this disorder at some point in their lives, though women are diagnosed more often than men. Panic disorder consists of sudden, overwhelming attacks of terror and worry about having additional panic attacks. The attacks seemingly come out of nowhere, though they may be brought on by external stimuli or internal thought processes. Panic attacks typically last for several minutes. Symptoms include sweating and trembling, a racing heart, shortness of breath, chest pain, dizziness, lightheadedness, and numbness and tingling in the hands and feet. People experiencing panic attacks often feel that they are going crazy, that they're dying, or as if they are about to be hit by a train and cannot escape. Panic disorder affects an estimated 3% of the population in a given year, and women are twice as likely to be diagnosed as men. Those who experience panic attacks attempt suicide much more frequently than those in the general population. Loosely translated, agoraphobia means fear of a gathering place. People who have agoraphobia fear being in situations from which escape is difficult or impossible. A wide range of situations may bring on their fears. For example, being in a crowded shopping mall, or using public transportation. Their fear is so strong that being in such situation causes panic attacks. Indeed, agoraphobia without panic attacks is quite rare. As a result, people who experience agoraphobia avoid going into open spaces or to places that might have crowds. In extreme cases, these people may feel unable to leave their homes. In addition to fearing the particular situations, many people with agoraphobia fear having a panic attack in public. Although people are anxious about different things, the etiology of various types of anxiety is best explained by the biopsychosocial approach. For example, temperaments are biologically determined aspects of personality. Children who have an inhibited temperamental style are usually shy and tend to avoid unfamiliar people and novel objects. These inhibited children are more likely to develop anxiety disorders later in life. They are especially at risk for developing social anxiety disorder. And people who have been categorized as inhibited before age 2 show a threat response to novel forces even as adults many years later. This finding suggests that some aspects of childhood temperament are preserved in the adult brain. In addition, many fears are learned. A person might come to associate something with fear through classical conditioning, such as developing a phobia of dentists by learning to associate going to the dentist with pain. Observational learning might also contribute to anxiety disorders. For example, someone could develop a fear of flying by observing another person's fearful reaction to the closing of cabin doors. Such a fear might then generalize to other enclosed spaces, resulting in claustrophobia, or a fear of confined spaces. Some disorders have unwanted and intrusive thoughts that increase anxiety. The comedian and game show host Howie Mandel is famous for giving his guests a fist bump rather than shaking hands with them. What viewers didn't know was that Mandel had a serious psychological reason for using his signature greeting. He was obsessed with germs. In 2009, Mandel publicly announced that he had been diagnosed with obsessive-compulsive disorder, OCD, a condition that had been ruling his life for many years. And so far, you've learned that many psychological disorders involve both emotional and cognitive impairments. In some cases, the occurrence of unwanted thoughts leads to emotional distress. The DSM-5 categorizes a number of disorders that involve experiencing unwanted thoughts or the desire to engage in maladaptive behaviors. Obsessive-compulsive disorder involves frequent intrusive thoughts and compulsive actions. Affecting 1% to 2% of the population, OCD is more common in women than in men, and it generally begins in early adulthood. OCD includes two aspects of disordered thoughts and behaviors. Obsessions are recurrent, intrusive, and unwanted thoughts or urges or mental images that increase anxiety. They often include intense worry and fears of contamination, of accidents, or of one's own aggression. Compulsions are particular acts that the person feels driven to perform over and over again that reduce the anxiety. The most common compulsive behaviors are cleaning, checking, and counting. The key in this disorder is that when the person engages in the compulsive behavior, he or she experiences a temporary reduction in the anxiety caused by the obsession. For instance, a person who has an obsessive fear of germs might engage in the compulsion of repeatedly washing his hands. People diagnosed with OCD are aware that their obsessions and compulsions are irrational, yet they are unable to stop them. OCD is another example of how the biopsychosocial approach explains the causes of some psychological disorders. One explanation is that the disorder results from psychological factors, such as learning by conditioning. Anxiety is somehow paired to a specific event, probably through classical conditioning. The person then engages in behavior that reduces anxiety. The reduction of anxiety is negatively reinforced through operant conditioning, and the chances of engaging in that behavior again are increased. This type of learning can happen to anyone. For instance, if you're forced to shake hands with a man who has a bad cold, you'll likely feel anxious or uncomfortable because you do not want to get sick. As soon as the pleasantries are over, you run to the bathroom and wash your hands. Afterward, you feel relieved. Because you have paired hand washing with a reduction in anxiety, you're more likely to wash your hands in a similar situation in the future. For people who develop OCD, however, the compulsive behavior will reduce the anxiety only temporarily, so they will continue to experience repeated, disruptive, obsessive thoughts, for example, about germs. In turn, they will perform the behavior again and again in attempts to reduce the anxiety. However, there is also good evidence that the etiology of OCD is in part biological. Specifically, OCD seems to have a genetic origin. Various research methods, such as twin studies, have shown that OCD runs in families. The specific mechanism has not been identified, but the OCD-related genes appear to control the neurotransmitter glutamate, which is the major excitatory transmitter in the brain, and it increases neural firing. Brain imaging has also provided some evidence regarding a brain system involvement in OCD. In people with OCD, the caudate, a brain structure involved in suppressing impulses, is smaller and has structural abnormalities. It is possible that in people with OCD, the caudate does not function properly to prevent impulses from reaching conscious awareness. OCD is not the only type of psychopathology that can produce unwanted and intrusive thoughts. Such cognitive problems can also be caused by disorders that result from experiencing or witnessing life-threatening events or sexual violations. The DSM-5 categorizes a number of disorders together that result from trauma or excessive stress. This category describes trauma and stressor-related disorders. For example, a person who cries continually, has difficulty studying, and avoids social settings for 6 months after a romantic breakup may have an adjustment disorder. This person is having difficulty adjusting to the stressor. When people experience severe stress or emotional trauma, they often have negative reactions long after the danger has passed. In several cases, they develop post-traumatic stress disorder, or PTSD. This disorder involves frequent and recurring unwanted thoughts related to the trauma, including nightmares, intrusive thoughts, and flashbacks. Various types of traumatic experiences can lead to PTSD, such as having a serious accident, experiencing a sexual assault or rape, fighting in active combat, or surviving a natural disaster. Around 4% of people having experienced a trauma are likely to develop PTSD, although the risk of PTSD varies greatly by the type of trauma that's experienced. In addition, there are gender differences in PTSD, where women are more likely to develop the disorder. An opportunity to study susceptibility to PTSD came about because of a tragedy at Northern Illinois University in 2008. On the campus, in front of many observers, a lone gunman killed 5 people and wounded 21. Among a sample of female students, those with certain genetic markers related to serotonin functioning were much more likely to show PTSD symptoms in the weeks after the shooting. In support of the diathesis stress model, this finding suggests that some individuals may be more at risk than others for developing PTSD after an exposure to a stressful event. Those with PTSD often have chronic tension, anxiety, and health problems, and they may experience memory and attention problems in their daily lives. PTSD involves an unusual problem in memory, the inability to forget. People with PTSD also pay a lot of attention to stimuli associated with their traumatic events. For instance, soldiers with combat-induced PTSD show increased physiological responsiveness to pictures of troops, sounds of gunfire, and even words associated with combat. It is as if the severe emotional event is over-consolidated and incredibly memorable, so the person is always on the alert to experience a similar situation. In effect, PTSD interferes with the various brain processes that normally lead to extinction in fear learning, so it's difficult to unlearn the fear associated with the event. When people feel down or sad about something, they often say they are depressed. These emotions are relatively common, perhaps for some people during the winter. In fact, if you've ever experienced the blues during winter, then you may have had a mild form of depression. However, only lasting episodes of depressed mood that impair a person's life, cause significant distress, or both are diagnosed as depressive disorders. Depressive disorders are a type of mood disorder that features persistent and pervasive feelings of sadness, and they are very common. 2 types of depressive disorders are summarized here. The common feature of all depressive disorders is the presence of a sad, empty, or irritable mood. In addition, people with depressive disorders experience bodily symptoms and cognitive problems that interfere with daily life. The classic disorder in this category is major depressive disorder. According to DSM-5 criteria, to be diagnosed with a major depressive disorder, a person must have one of 2 symptoms: very depressed, often irritable mood, or a loss of interest in pleasurable activities for 2 weeks or more. In addition, the person must have other symptoms such as appetite and weight changes, sleep disturbances, loss of energy, difficulty concentrating, feelings of self-reproach or guilt, and frequent thoughts of death, perhaps by suicide. Major depressive disorder affects about 7 to 8% of Americans in any given year, and approximately 16% of Americans will develop major depressive disorder at some point in their lives. Although major depressive disorder varies in severity, those who receive a diagnosis are highly impaired by the condition. It tends to persist over several months, sometimes lasting for years. Some people experience repeated episodes of major depressive disorder over their lives, and women are nearly twice as likely as men to be diagnosed with major depressive disorder. Unlike major depressive disorder, persistent depressive disorder is of mild to moderate severity. People with persistent depressive disorder, approximately 2 to 3% of the population, may have many of the same symptoms as those with major depressive disorder, but the symptoms are less intense. To be diagnosed with persistent depressive disorder, someone must have a depressed mood most of the day, more days than not, for at least 2 years. Periods of persistent depressive disorder last from 2 to 20 or more years, although the typical duration is about 5 to 10 years. Depression is so prevalent that it's sometimes called the common cold of psychological disorders. In its most severe form, depression is the leading cause of disability in the United States and worldwide. Depression is the leading risk factor for suicide, which claims approximately 800,000 lives annually around the world and is among the top 3 causes of death for people between 15 and 35 years of age. Unfortunately, some people do not seek treatment because of the stigma associated with having a psychological disorder. And one way to combat this stigma is to focus attention on how common they are and to educate more people about effective treatments. Depressive disorders are so common that people often wonder what causes them, and the answer to that is not simple. As with other psychological disorders, biopsychosocial factors play a role in the etiology of depression. Let's look at each of these influences. Studies of twins, of families, and of adopted children support the notion that depression has a genetic component. Although there is some variability among studies, it is more likely that both identical twins will have depression than both fraternal twins will. The existence of a genetic component implies that biological factors are involved in depression. In fact, there is evidence that major depression involves various neurotransmitters that regulate emotion, and medications that increase or decrease the availability of specific neurotransmitters are used in the treatment of depression. In addition, studies of brain function have suggested that certain neural structures may be involved in mood disorders. Damage to the left prefrontal cortex can lead to depression, but damage to the right prefrontal cortex does not. Biological rhythms also have been implicated in depression. People who experience depression enter REM sleep more quickly and have more of it. In fact, one symptom of depression is excessive sleeping and tiredness. Psychological factors also play a role in the cause of depression. A number of studies have implicated life stressors, such as the death of a loved one, a divorce, or multiple negative events in many cases of depression. How people react to stress, however, can be influenced by their interpersonal relationships, and relationships play an extremely important role in depression. A person who has a close friend or group of friends is less likely to become depressed when faced with stress. This protective factor is related not to the number of friends, but to the quality of the friendships. One good friend is more protective than a large number of casual acquaintances. A second cognitive theory of depression is based on learned helplessness. In this case, people come to see themselves as unable to have any effect on events in their lives. The psychologist Martin Seligman based this model on years of research with non-human animals. When animals are placed in unpleasant situations they cannot escape, the animals eventually become passive and unresponsive. They end up lacking the motivation to try new methods of escape, even when given the opportunity. Similarly, people who are experiencing learned helplessness come to expect that bad things will happen to them and believe they are powerless to avoid negative events. Their explanations for negative events refer to personal factors that are unchanging rather than to situational factors that are temporary. This pattern leads them to feel hopeless about making positive changes in their lives. Unfortunately, this hopelessness is a key symptom of depression that can lead to thoughts of suicide. In its most severe form, depression is the leading cause of disability worldwide and affects more than 300 million people. For example, major depressive disorder affects about 41 million people in India and 49 million people in China. Unfortunately, in both countries, there are large gaps between the number of people who have psychological disorders and the resources to treat these people. The stigma associated with depressive disorder has especially bad consequences in developing countries where people do not take advantage of the treatment options because they don't want to admit to being depressed. Across multiple countries and contexts, twice as many women as men are diagnosed with depression. Furthermore, gender roles may lead to discrepancies in the experience of depression. One theory is that women respond to stressful events by internalizing their feelings, which leads to depression and anxiety, whereas men externalize with alcohol, drugs, and violence. How have you been feeling for the past week? Perhaps on some days you were happy, and on others you were sad. We all experience variations in mood. Our typical fluctuations from happiness to sadness seem small, however, compared with the extremes experienced by people with bipolar disorders, who experience episodes of greatly elevated mood. These periods of greatly elevated mood can vary in degree and are accompanied by major shifts in energy level, physical activity, and creativity. The two main types of bipolar disorders, each of which are characterized by different degree of elevated mood, are summarized here. True manic episodes last 1 week or longer and are characterized by abnormally and persistently elevated mood, increased activity, diminished need for sleep, grandiose ideas, racing thoughts, and extreme distractibility. For some people, mania involves a sense of agitation and restlessness rather than positivity. During episodes of mania, heightened levels of activity and extreme happiness often result in excessive involvement in pleasurable but foolish activities. People may engage in sexual indiscretions, buying sprees, risky business ventures, and similar out-of-character behaviors that they regret once the mania has subsided. This condition is known as bipolar I disorder. Bipolar I disorder is based on the presence of extreme mania. Although those with bipolar I disorder often have depressive episodes, such episodes are not necessary for a DSM-5 diagnosis. Furthermore, the mania experienced in bipolar I disorder can be so severe as to make it hard for a person to know what's real, such as if the person experiences severe thought disturbances or hallucinations. This extreme form of mania can cause significant impairment in daily lives and often can result in hospitalization. Compared with bipolar I disorder, in which people experience true manic episodes, those with bipolar II disorder may experience less extreme mood elevations called hypomania. These episodes are often characterized by heightened creativity and productivity, and they can be extremely pleasurable and rewarding. Although these less extreme mood elevations may be somewhat disruptive to a person's life, they do not cause significant impairment in daily living or require hospitalization. However, the bipolar II diagnosis does require at least one episode of major depression. Therefore, depression might cause significant impairments to stress or both. Thus, impairments in daily living for bipolar I disorder are the manic episodes, whereas the impairments for bipolar II disorder are the major depressive episodes. The psychology professor Kay Redfield Jamison acknowledged her own struggles with bipolar disorder in her award-winning memoir, An Unquiet Mind. Her work has helped shape the study of the disorder. Her 1990 textbook, co-authored with Frederick Goodwin, is considered the standard for the field. In An Unquiet Mind, Jamison details how, as a child, she was intensely emotional and occasionally obsessive. When she was 17, she had her first serious bout of what she describes as profoundly suicidal depression. Jamison experienced deepening swings from wild exuberance to paralyzing depression throughout her undergraduate years. In 1975, after obtaining her PhD in clinical psychology, she joined the UCLA Department of Psychiatry, where she directed the Affective Disorders Clinic. Within months after she began this job, her condition deteriorated dramatically. She began hallucinating and feared that she was losing her mind. This state so terrified her that she sought out a psychiatrist who quickly diagnosed her as having bipolar disorder and prescribed a drug called lithium. Although lithium has helped Jamison, she also credits the psychological support of her psychiatrist as well as her family and friends. An unfortunate side effect of lithium is that it blunts positive feelings. People with bipolar disorder experience profoundly enjoyable highs during their manic phases, so they often resent the drug and refuse to take it. Jamison has made the point that lithium can rob people of creative energy. In her 1993 book, Touched with Fire, Jamison asked whether lithium would have damaged the genius of major artists and writers who may have had bipolar disorders, such as Michelangelo, Vincent van Gogh, Georgia O'Keeffe, Emily Dickinson, and Ernest Hemingway. Jamison demonstrates the strong association between bipolar disorder and artistic genius, and she raises the disturbing question of whether eradicating the disorder would rob societies of much great art. Jamison embodies this irony. Her early career benefited from the energy and creativity of her manic phases, even as her personal life was threatened by devastating depression. Bipolar disorders are much less common than depressive disorders. Around 3 to 4% of the population will experience a bipolar disorder in their lifetimes. Whereas depression is more common in women, bipolar disorders are equally prevalent in women and men. Bipolar disorders emerge most commonly during the late adolescence or early adulthood. Bipolar I disorder is typically diagnosed at an earlier age than bipolar II disorder. There is a very strong genetic component to bipolar disorders. Twin studies reveal that if one twin has the disorder, an identical twin is 3 times more likely to have the disorder than a fraternal twin is. In the 1980s, the Amish community, a self-contained religious community centered largely in Pennsylvania, was involved in a genetic research study. The Amish were an ideal population for this sort of research because they keep good family history records and few outsiders marry into the community. In addition, substance abuse is virtually non-existent among Amish adults, so psychological disorders are less likely to be confused with it. The research results revealed that bipolar disorders ran in a limited number of families and that all of those afflicted had a similar genetic defect. Subsequent studies of this Amish group have identified several other potential genes involved in bipolar disorder. Recent genetic research has found that the hereditary nature of bipolar disorders is complex and not linked to just one gene. Current research focuses on identifying several genes that may be involved. In addition, it appears that in families with bipolar disorders, the disorders are more severe and appear at younger ages in successive generations. Research on this pattern may help reveal the genetics of this disorder, but the specific nature of the heritability of bipolar disorders remains to be discovered.